Yeah, no, definitely. So the area within ophthalmology that's my particular research interest is our vision outcomes among patients with diabetes, because diabetes is still the leading cause of vision loss among patients who are, working age adults in the US. And we see a big difference in terms of vision impairment from diabetes by race and ethnicity. And so I think with this study, what we were trying to look at was the interplay between community and socioeconomic deprivation and the impact by different race and ethnicity categories. Because ultimately we want to get to a place where of health equity, where all patients have similar outcomes. Yeah, I think this is one of the studies that probably brings out more questions than it answers, which I think is, part of research to figure out which direction is interesting and people should go down. But we were basically finding that among non-Hispanic white patients, where the neighborhood socioeconomic deprivation really matters, were patients who are coming from neighborhoods with higher socioeconomic deprivation were way more likely than those coming from more socioeconomic advantage to have a lapse in diabetic retinopathy care. But when looking at non-Hispanic Black patients, Hispanic patients, and patients of other race and ethnicity groups, we were finding that patients, no matter which neighborhoods they were coming from, they all were more likely to have a lapse in diabetic retinopathy care compared to non-Hispanic white patients. And so more research is definitely needed to understand why we're seeing these different patterns, because I think that will give us highlights and insights into what policy changes can impact health outcomes. Yeah, I mean, I think there are many articles out there now in medicine, not just, in ophthalmology, but looking at historic redlining and vision outcomes. And so there are definitely broader impacts and downstream results from structural racism and these redlining policies. I'd say our study didn't look at that specifically, but, just thinking about what could be causing these different trends that we're looking at, that's definitely one of the possibilities. Yeah, I mean, I think certainly for diabetic retinopathy care, I think there's more that we can do. We know that when patients don't follow up with us, that's when they develop the vision-threatening disease and then leads to vision loss that's, irreversible. And so I think as clinicians, it's being really mindful that some communities and some groups just need more help than others in returning for care. And how do we think about changes that we can institute within clinic to help those groups that I think are critical? Yeah, I'd say, the specific social risk factors of individuals beyond, race and ethnicity, like what are they struggling with in their lives outside of their medical care? I think really being able to grasp that as part of clinical routine care is probably going to help us a lot in terms of improving outcomes. Yeah, I mean, this is a big space. Lots of people are working on it, and I think it's great that so many people are trying to tackle this. And at least in terms of my research, trying to look at ways that we can leverage informatics and our electronic health record to help us tackle these issues.